So today I want to share with you a little bit about both some research that I've done recently on COVID-related, on kind of how we can use data to inform decision-making around the pandemic, and just give some kind of background. I think all of us have become sort of experts in epidemiology over the last 2 years, but give you some kind of a frame of how we think about it from a data perspective. So I want to pose this. This is one example of kind of the very first use of kind of data in an epidemiologic sense. So this was an outbreak that happened in 1854 that killed hundreds of people in London, a cholera outbreak. Cholera is spread typically through contaminated water. And this physician named John Snow, no relation, of course, to our beloved Game of Thrones character. Any Game of Thrones fans? No? Okay. You know nothing, yes. So Dr. Snow was the first to make this really interesting observation. And what he noted was this water pump is just located here at this red dot. He drew this map and he plotted the data where each one of these bars corresponds to a death. And what he noticed was that a lot of the deaths were clustered around this particular water pump. And what was happening kind of in the background, London didn't have, they had some modern sanitation, but the city had grown so quickly, so the kind of sewers and things like that weren't really maintained. So near the location of this water pump, people had cesspools kind of under their houses. A lot of kind of gross stuff went in there, and it contaminated the water supply to this pump. And so many people who would go into this water source to get their drinking water ended up contracting cholera and dying as a result. So we often credit him, and he actually at the time was not very popular. A lot of other physicians said, no, cholera is spread through the air, it can't be through this. He used this to sort of document evidence showing, no, in fact, I think this is passed through unclean water. And he had the pump, this is kind of a replica of the pump, but he had the handle on the pump removed and is credited with saving potentially hundreds of lives because they shut down the water at that source. So again, this, when we think about epidemiology, we're often thinking about how can we use data to sort of inform public health decisions. More broadly, this is kind of how I think about how data can be used both in public health and more broadly in business. So classically, we think about kind of a divide between statistics, which is sort of a more traditional, older field, and analytics. Here, I'm describing statistics in kind of two ways. One is descriptive statistics. This is things like if you have a set of data and you want to calculate the mean, the standard deviation, and so forth, it's kind of what do we know? What happened looking back? Inferential statistics, on the other hand, is about using that data to try to make inferences about something else. So I might take a sample of households and try to make some inferences about average income, average spending habits, that sort of thing. On sort of the newer area of analytics, we sort of see two broad areas for this. So one is what we call predictive analytics. So this is trying to use historical data to either forecast or estimate what might happen in the future or what might happen under some kind of counterfactual scenario. But it's really just about making a prediction. And then finally, and I'll talk a little bit about this later, we think about prescriptive analytics is about using that data to actually make decisions. So how can we change how we might do something in light of this kind of data? And let me also say, guys, too, as I'm going through this, please feel free to stop me if you have any questions or clarifications or anything. Okay, so a little bit of Epidemiology 101. I think all of us have probably heard of this term R naught, the basic reproduction number, thanks to the pandemic. For those of you who have been living in a cave for the last 2 years, this is a measure that indicates whether or not an epidemic will theoretically die out or persist in the population. If we see an epidemic has value less than 1, it dies out. If it's greater than 1, it continues. And then there's something called the herd immunity threshold. This is kind of the minimum vaccination threshold that we need to achieve in the population to allow the disease to die out. In other words, to get that R naught, or the effective reproductive number, below 1. And I'm showing you here for some common diseases. COVID-19 is estimated to have an R naught of about 2 to 4. So we need to get somewhere between 50 and 75% vaccination rates to achieve that herd immunity threshold. If we contrast that to something like measles, which is one of the most infectious diseases that we know of, that has an R naught of at least 12, and we have to get very, very high vaccination numbers, above 90%, in order to see that die out. And that's partially why we've seen a resurgence in measles cases, because we've seen some communities dip below that. Okay, if you guys recall back to early 2020, one of the first instances of COVID that was happening were on cruise ships. So I was tracking this with a lot of interest because it was kind of a perfect experiment, or natural experiment from a data point of view. So this was the Diamond Princess cruise that was docked off Japan for many days. There were 3,700 passengers on board. In January again, this is 2020, it leaves on a 2-week tour. On January 25th, one passenger disembarks in Hong Kong, and about 5 days later, that passenger tests positive for COVID. As a result, the ship was quarantined off the coast of Japan, and about 2 weeks later, several hundred Americans disembarked. Many of them flew home, of course, and we didn't do a very effective quarantining for them. By the end of February, the remaining passengers had disembarked. And in the end, there were over 700 people infected and about 10 deaths. And this plot shows you over time the cumulative number of infections, right? So this is kind of a classic epidemic curve. We see this sort of S-shape to it where the disease is kind of starting out, it kind of gains some traction, and then at some point it reaches sort of a natural saturation. You see this same kind of curve in things like marketing, right? So when we think about new product adoption, we have the early adopters and then sort of the mainstream people, and then eventually kind of the Luddites who might adopt a new technology. Same kind of phenomenon that's driving that. So if I have data like this from something like a cruise ship, and the reason why I say this is a great natural setting is nobody was getting on or off the boat. It was an entirely closed population, which we rarely have a setting like that. I can write down, this is what we call an SEIR. It's a variation of an SIR model. It stands for susceptible, exposed, infected, and recovered. I'm not going to go into sort of the math, but just the basic intuition behind it is I put everybody in the population into one of these 4 buckets based on your health status. So if you're uninfected, you're susceptible. If you become exposed, you move to this bucket. If you become infected, then you move to that bucket, and then finally removed, either due to immunity or death. And then we have these kind of arrows representing the flows between these different compartments, and with various kind of Greek letters representing the rates of those people moving. And then what I can do is I can take a model like this, I can plug in the data for our Diamond Princess cruise, and then I can formally estimate the value of these parameters, and I can come up with a number for R naught. So based on the Diamond cruise, again, this is a really crude model, but based on this cruise data, we would estimate an R naught of 3.4, which is kind of right in that 2 to 4 window that a lot of other epidemiologists were estimating. So how can we reduce R naught? So again, we talked about how you want to get R naught below 1 in order to have the epidemic die out. This epidemiologist describes kind of 4 inputs to any infectious disease. We have the duration, which is how long a person is infectious. Opportunity is the number of potential events or opportunities that they could spread it during their infectious period. Transmission is the probability that one of those opportunities leads to transmission of the disease. And then finally, the susceptibility is how vulnerable the uninfected population is. So if you were to put on a hat of let's say a policymaker, and you wanted to reduce R naught, what are some things that we could do? And face masks. And which of these might that affect? Which of these 4 things? Sorry, transmission, right? The probability that any particular contact leads to infection. Absolutely. What else can we do?
Quarantine.
Yeah, I was going to say, what's happening in Shanghai right now, right? Mass quarantining. So how does quarantining, what would that have an effect on? Opportunities, right? You can't infect somebody if you're stuck at home and not going anywhere. Other thoughts?
Improve ventilation.
Improve ventilation. So before you all entered, I did crank up this HEPA filter right here that I'm going to stand next to. But yeah, improve ventilation on airplanes, in buildings, and so forth. What might that affect? Yeah, the probability that it leads to it. That's right. Anything else? Yes. Vaccinations, and which one does that affect? Susceptibility. So no, we've covered all of them except duration. Any guesses on that one? Yeah, so a lot of the antivirals are thought to sort of suppress your viral load and potentially reduce that time. So you guys got it, A+, exactly right. We have a set of these interventions in our kind of toolbox, and they're, the broad objective of them is to not only to save lives, but to also reduce R naught. This is just an illustration of one such intervention. This is a beach in Florida. Economists love these kind of interventions because they create a perfect natural experiment. What happened here, Duval County closed all the beaches, St. Johns County did not. And that's about the county border. And so you can see, these two lone people kind of patrolling. But this type of experiment allows us to be able to kind of estimate what is the effectiveness of something like beach closures on transmission, because you have this natural discontinuity in the data. Okay, so when we think about epidemic analytics, there's a lot of exciting things happening. I'm going to talk about one of these in a minute with a study that I did. But where we collect data from is constantly changing. So the big thing that a lot of researchers are using now is smartphone data or geolocation mobility data. I'll tell you about an example of a study I did using that shortly, but people are using this for looking at consumer activity, looking at digital contact tracing, compliance with stay-at-home orders, and so forth. There was a couple cool studies that came out during COVID on smart thermometers. So there's a handful of these that connect to an app, and it can tell based on if somebody's temperature is elevated, where COVID hotspots might be occurring before those patients went to, let's say, an emergency room. Things like Twitter and Facebook are great sources of data. People are always mining them to look for, if there's an outbreak in a particular community, kind of who might be at that same party on Facebook. And then online reviews are another great source. So one of my favorite articles that came out during this was using Amazon reviews to try to predict COVID. So this kind of blogger talked about reviews for scented candles. So kind of in late 2020, these are just examples, but a number of these reviews, this says, "I'm sorry, this smells like cat urine." One of the side effects of COVID is a loss of smell. So this graph on the right shows the percentage of reviews that mention no smell. And we see that this is from 2020, January to December. So as kind of the pandemic really took off, we see more and more reviews mentioning a lack of smell. So, may not be a perfect study, but it's interesting to sort of think about where you can gather this kind of information online. Question, yep.
I've heard that they're checking wastewater, and they're able to detect there too?
Yeah. So the question was about wastewater. So this has been a huge area where it's really exploded. That no pun intended. That people shed the virus long before they're infectious, and so wastewater detection has been a huge area. I don't know if LA has been doing it as much. I know I used to live in New Haven, Connecticut, and they were doing a lot of it early on, and it was pretty predictive.
UCLA is doing it.
Oh, UCLA is doing it. Oh, I didn't know that. Okay, good to know. Yeah. Okay. So that's kind of an overview of how we think about using data to manage a pandemic. Let me tell you now a little bit about two studies that I've been working on in the last year and a half or so using some of these data sources. So the first one is I'm going to describe COVID in nursing homes. This was a huge issue, particularly pre-vaccination. In the beginning of the pandemic, more than half of all deaths in the US were among the nursing home population. So that's an incredibly vulnerable population. They live in congregate settings. They're often elderly and have comorbidities. And so, it's just kind of the perfect recipe for a pandemic to kind of take hold and wreak a lot of havoc. More recently, last year, there was a federal vaccine mandate for COVID. As many of us may have heard, this actually was kind of appealed and went all the way up to the Supreme Court. And the Supreme Court overturned the mandate in general, but did uphold it for healthcare workers only as of January 2022 this year. Despite that, we still see pretty abysmal booster rates among nursing home staff. So this bar plot is showing as of February 2022, the fraction of nursing home staff that are boosted. This is, Puerto Rico is doing the best at about 85%. California is up here around 72%, all the way down to Florida, only about a quarter of workers are boosted. So this is still going to be, I think, an issue going forward. So in kind of at the start of the pandemic in early 2020, there was this outbreak that occurred at the Life Care Center in Kirkland, Washington. And this was, at the time, kind of the first documented cases in a nursing facility in the US. This outbreak in particular led to 167 cases, mostly among residents, but also some staff and visitors. And the CDC did a really detailed study. They actually used some genetic testing to link this particular facility to other facilities later on. So this facility I'm referring to had a shared health worker with this facility. They had an outbreak a few days later, and so on and so forth. And at the time, they also said, they mentioned that staff members who work in more than one facility may be contributing to the spread of COVID, but there were no policies implemented to reduce this. There was no additional kind of guidance to minimize this. And so the project that my colleagues and I were interested in is to look at first, how connected are nursing homes? So nobody really knows, how many people work in more than one facility and so forth. So can we document that? And then secondly, going back to kind of the predictive analytics question, are those connections predictive of COVID? So can we learn something? If I know how connected your nursing home is, can I learn something about the chance of you having a COVID pandemic or another pandemic? So some brief background on nursing homes. This is the first study I've ever done on nursing homes, so we had to learn a lot about this. Typically in a nursing home, and when I say nursing home here, I'm referring to what's called a skilled nursing facility, or a SNF. There's about 15,000 of these in the US. These are the places that often people go to if they're recovering from a surgery or perhaps long-term care. I'm not talking about the independent kind of living or assisted living centers. SNFs are actually regulated by Medicare, so we have a lot of data and information about where they're located and so forth. It's estimated because SNFs have to meet minimum staffing thresholds. Many of them rely on temp agencies. So what do I mean by that? So in California, we require every resident to have 3.5 hours of staff contact per day. And if somebody is calling in sick or can't come to work, they have to bring in a temp worker. And so as a result, about 60% of homes rely on these temp workers. There's also frequent use of contract workers, so things like occupational therapists, hairstylists, they sort of will float around and go to many different facilities. And given their pay, it's estimated that kind of the typical nursing assistant in the US makes less than $29,000. Many of them are forced to work multiple jobs, and hence they work in multiple facilities. So our big challenge was we have this research question. How do we go about doing this? How do we collect the data that we need? There's no databases that show this employee worked in this home and this home. Like that data does not exist. So we relied on smartphone location data. So my colleagues and I have access to this pretty cool data set. It's a little bit scary too, but it's a company called VeriSet. They're a spinoff of SafeGraph. This data has been all over the news, on how due to privacy concerns, how you can track individual movement and so forth. Fortunately, they make their data available to enterprising faculty. And so we worked with this data for a couple of projects. So for this particular project, we had 50 million smartphones in the US, so a pretty big sample. The data generates 5 billion observations per day. So think of it as, where this data is coming from is if you open your smartphone and let's say you're requesting an Uber, Uber is kind of pinging your location in the background, your latitude and longitude. Uber then sells that data to a third-party data aggregator. A bunch of these apps sell that data, and those third-party data aggregators then sell it to hedge funds and others, or to faculty. This is changing a little bit now because Apple has actually made it a little bit harder. So now if you open a new app, it'll give you the chance to opt out of this. It says do not share my info. So I think this data source is really going to kind of dry up in the next couple of years. But for now, we're trying to write as many papers as we can. So each observation will report the smartphone ID, the latitude and longitude, the time, and so forth. And again, this is not like the cell tower. This is the GPS coordinates. So it's like when you open maps and you see that little blue dot, that's what we're getting. And so it's pretty precise. And what we found is that this data are most useful when it's combined with other data. So we've done some other papers. I worked on a paper where we looked at how quickly people respond to a hurricane alert, like how quickly do people evacuate using smartphone location data. And my colleague, Keith, also wrote a paper where he looked at, kind of partisanship following the 2016 election in the US. Thanksgiving was a couple weeks later. Basically, he looks at, do families that are half Democrat and half Republican, do they have shorter Thanksgivings? And the answer is yes, compared to prior years. Perhaps not surprising, right? That was a really divisive time in this country. So we've tried to do some really neat projects with this type of data. So here's what, to give you a sense of what it looks like, showing you in red is a nursing home from kind of a Google Maps satellite image. So we can get these shape files from Google, and then we construct this kind of yellow polygon around that, and we say we're going to include a smartphone if it pings inside that polygon. And to avoid sort of people walking down the street accidentally throwing off a ping, we make sure that it produces at least 3 pings inside the polygon, and that the smartphone spends at least 1 hour inside. So we're not going to include the UPS driver who drops off a package, but we want to get people who are likely the workers in there. One thing that we're taking advantage of is in March 2020, the Centers for Medicare and Medicaid, again, who regulate nursing homes, they issued nationwide visitor lockdowns. So if you recall, after that point, nobody could go and visit a nursing home except for the workers. So we're allowed to, again, have kind of this controlled sample where everybody going in and out is either a resident or a worker. In the end, we're left with about 500,000 smartphones. That's how big this data is that entered one or more of these facilities. And on average, they return to homes 16 days, and only about 5% of phones visit more than one facility. So the majority of phones of workers or residents are in one facility. The question is how kind of infectious are those 5%? So I won't, again, go into the math of this, but just understand we take this smartphone data, and then we're able to construct a bunch of interesting measures. So this ends up forming kind of a social network. So what I mean by that is imagine a network where you have nodes and edges. Nodes represent nursing homes. Edges are those links between them, so a worker who works in more than one facility. And then we can use a number of standard network theory metrics like degree. That's how many nursing homes are you connected to? Strength is how many workers work in this facility and another facility. There's this cool one called eigenvector centrality. This is a measure, it's used in kind of Google's PageRank algorithm. It's the idea, it's not, in social network theory, it's not how many friends do you have, but it's how popular are your friends? How important are your friends in the overall network? And so we wanted to measure that as well. So let me show you an image of what I mean by a network. Here, again, the circles represent individual nursing homes. Here, the blue one is going to be the hub. That's going to be the nursing home I'm focused on, that one up there. The dark gray circles are nursing homes that share at least one worker with the hub. And then the gray, and we call those the neighbors. And then the gray ones are the neighbors' neighbors, right? And the color of the line is how many workers appear in both of those facilities. So in most cases, it's just one worker might appear in both of these. In some, we see like 2 workers appear in both of those, and so forth. So if I come back to the facility I mentioned at the beginning that had that first outbreak in Kirkland, Washington, that was called the Life Care Center. That's this blue one. Using this smartphone data, we see they're on average connected to 7 other nursing homes, and so forth. This eigenvector is scaled between 0 and 1, so they're kind of on the lower side of that. But what's interesting is, let me point you in direction to 2 of their neighbors. So this home shares workers with these 2 nodes, which are these 2 facilities. And what we see is those facilities are super connected. So connected to 25 other facilities or 23 other facilities. This has an eigenvector of 1, which means it's the most connected or popular nursing home in the state of Washington. And so it's perhaps not surprising that they had this huge outbreak that then propagated to other connected nursing homes. If you notice one other thing, if you look at the logo of these 3 facilities, they have a common ownership structure. So it's likely that there's workers that are just working in both facilities. Here's some other networks, just for illustration purposes. This is a network in Alabama. This is in California. Florida just looks like a giant bowl of spaghetti. It's like all of the nursing homes are connected to each other. And this is a facility in Georgia. Where you see a node, and then you sometimes see these like little pockets, but shared workers are kind of bridging those connections. So I promise I'm only going to show you one regression table because I'm a stats professor, and I would be remiss not to remind you all of your MBA experience in learning regression. But let me just say what I'm doing here is this is kind of the second goal of our research question. So we want to know how predictive are these network measures of COVID. The short answer is they're highly predictive. So if I regress the number of cases on any of these network measures, we get positive and very highly significant coefficients. And so the punchline is that these network measures are highly predictive of COVID, even after throwing in a bunch of controls and doing a whole bunch of other fancy stuff and robustness checks is something that really holds. Interestingly, CMS, the Centers for Medicare and Medicaid, they also rate nursing homes like on a 5-point scale, and they issue violations. So they do inspections of nursing homes, and if somebody, if they're not wearing PPE or they're not following protocols, they'll get like written up for it, like a violation. None of that is predictive of COVID in these nursing homes. The thing that matters is if those workers are working in multiple facilities. So our punchline is that these connections are highly predictive. A few other things are modestly predictive, like for-profit status and so forth. We estimate that if you could have magically kind of waved a wand and shut down all shared staff, that we could have prevented about half of all nursing home cases, which would have drastically saved a lot of lives. Of course, hindsight is 20/20, but that's how much the shared staff contributes to the spread of COVID. And then finally, we put together a website with the goal of kind of enabling nursing home managers to go and see who else they're connected to. So, if there's an outbreak of COVID, the idea is, facility A could quickly contact its 10 connections and say, hey, we've had an outbreak here, let's implement additional screening or additional masking or that sort of thing in a kind of a quick fashion in order to mitigate the chance of a pandemic or an outbreak. We've been sharing this tool both with the LA Department of Public Health as well as a few other jurisdictions out east and some nursing home networks and so forth. And I think the thing that I'm most proud about, actually, this is a first for me, was when this was discussed before the Supreme Court in an amicus brief, they actually cited this paper as evidence of this is why we have to have a vaccine mandate for healthcare workers. Yeah, that will probably never happen again in my career, but I'll take a win when I get it. Okay, so that's the first project I want to mention. The next one, I just want to briefly spend about 5 minutes describing a slightly different type of analysis. The nursing homes one was really an example of kind of, what we would call statistics, inferential statistics, and some predictive analytics. This next project I'm going to mention is really about prescription. So it's about, what do we do with this information and this data? Okay, so here it's also COVID related, but focusing on vaccinations. So as many of us may have heard, about a year ago, the federal government launched something called the Federal Retail Pharmacy Program. This is a partnership between the U.S. federal government and pharmacies like CVS, Walgreens, et cetera, to administer COVID vaccinations. So the partnership involves about 41,000 pharmacies nationwide. And as of this month, more than 240 million vaccinations, I think doses, have been administered through this partnership. So it's really where most of us are getting vaccinated. But let me show you some data, okay? So, when you think of this kind of partnership, it seems like a great thing, right? Pharmacies are everywhere, except it turns out they're not. So if I look at, this is Cook County, Illinois, just outside Chicago, which includes Chicago. These red dots are showing the current locations of all of those vaccination sites. And then here I'm color coding, these are census tracts. I'm color coding them based on distance to the nearest site. So the lighter shading means there's a location near you. The darker shading means you'd have to travel more than 5 kilometers to get a vaccination. We're imposing some assumptions, which is we assume there's fixed capacity at the store. So you can't have one store and have 10 million people go to it. So there's some kind of capacity constraints. So what's happening is this program, which is, it seems like a great thing on paper, it's kind of creating what we sometimes call vaccination deserts. It's creating communities that have to travel a disproportionate long distance, and these are the very communities that have been unfortunately hit hardest by pandemic, lower income minorities, people of color, and so forth. So what we propose in this paper is a solution where we augment these locations with dollar stores. So it turns out dollar stores tend to locate in lower income communities. And here I'm showing you basically the same map holding constant the total number of stores. So there's no free lunch here, right? I'm not adding stores. I'm just substituting in $262 stores. And we see the average travel distance drops from about 7 kilometers to less than 1 kilometer, right? You guys are all upper SES, can get in a car, can take off work, can do all of that. A lot of these communities, people don't have access to transportation and so forth. And so bringing the vaccinations to them is just a nice solution. So this director of the CDC had actually discussed, we didn't just pick dollar stores for no reason. The director of the CDC, Rochelle Walensky, had mentioned kind of proposed potentially partnering with dollar stores, but it kind of never went anywhere on a national level. And so what we're doing is showing across the US kind of what effect this could have. So let me just briefly show you, and then I'm going to wrap up, some other locations to illustrate kind of what effect this could have. This is New York City. As you can see, Manhattan is very dense, but also had a lot of participating pharmacies. There's over 1,000 in the 5-borough area. If I substitute just a small, like 10% basically or 15% of dollar stores, notice where they're disproportionately occurring, right? It's in Queens, the Bronx, Brooklyn. It's in some communities, again, that tend to have are sort of lower income, lower opportunity communities. This is Harris County near Houston. Again, sort of the same idea. And then lastly, of course, we did Los Angeles. To be fair, actually, California is one of the better states on this compared to Illinois and a few others. So we have pretty good coverage. I mean, there's a couple pockets that could be better. This is Compton and kind of South Central LA. And we show, you can mitigate some of this again by adding in dollar stores.
Did you pick the places to have the dollar stores based on how you could lower the average travel distance?
Yes.
Okay.
So the technical details, 5 seconds. This is this cool mixed integer linear program where we minimize average travel distance subject to some constraints, and then it's a facility location problem. So it's a classic problem. I'm an operations person. It's a classic problem in operations. Where to locate things to minimize distance. Same thing Amazon does. Where to locate its distribution centers to minimize travel costs and so forth. Yeah.
So why did you choose dollar stores instead of, say, something like a church?
Yes, great question. So I think it would be really neat to look at something like churches or Starbucks or whatever. Here, hopefully this answers your question. This is data, again, this is for California. No, I think this is nationwide, actually. This is nationwide, excuse me. So this is showing you, based on your income, the number of stores in your community, in your zip code. I think this is in your zip code. And what we find is like, the red are the pharmacies that are participating in this program. There's more pharmacies in higher income places, and there's more dollar stores in lower income places. So it kind of perfectly offsets in a way. I don't know enough about where churches located. I mean, they seem probably uniformly everywhere, so it wouldn't kind of fill that gap, but it would probably be the same idea. I mean, we would just have to get their locations and then run it through. Yeah. Okay, so let me just end with that slide. This is a new project. What we're working on right now is actually focusing on, California has like the best data when it comes to the pandemic. So we can get like weekly vaccination rates by zip code for the entire state. No other state does that, by the way, but our Department of Public Health is very good at collecting this data and making it available. And what we're doing now is we're looking at how much harder is it for lower income people to travel a distance? So here we're kind of assuming we're agnostic and we're saying, okay, if somebody has to travel 1 kilometer or 5 kilometers, that's equally burdensome. But in reality, of course, it's harder for somebody to travel, let's say 5 kilometers if you don't have a car than for somebody who does have a car. So we want to add in kind of a demand function that takes into account your income and some other characteristics to try to then say, if our goal was instead to maximize vaccinations, where might I locate these stores? Yeah, question?
So during the pandemic, when schools shut down,
I'm assuming that there were schools generally distributed even in the pharmacy deserts. So
Yeah.
could schools have been a location?
It's a good question. I don't think it solves like the rural issue. I mean, in that, people still have to travel further distances to schools, but we could, it's similar to churches, right? Like we could look at any other kind of network. We had thought, I mean, dollar stores are attractive in the sense that like, if lower income people go there to shop, you could think about some incentives, come and get your vaccine and we'll give you, $20 and free stuff, whatever, right? Like in some other work, I'm looking at opioid use in like pharmacy deserts, and I find that in communities that don't have access to a pharmacy, their doctors prescribe higher rates of opioids, higher doses, controlling for a whole bunch of other stuff. So it's not just because of income or poverty. That there's really, these have like big effects on people's lives, absolutely. Okay, so again, just a kind of a snapshot of what faculty do when we're not teaching is this kind of research. Let me just end by, I want to share with you, so I actually, this past fall, I teach our core data and decisions class for the full-time program. I've taught it every year since 2013. One of my former students here, Andrew, is here. This year we did a really exciting revamp. So we made it much more data focused, analytics focused. I taught actually in this room, you can see our students are doing group labs where they're learning to code in R. And they would sit around each one of these televisions, connect a computer, and then kind of one person would be driving it and they'd be working together on it. And so, I mentioned this because, I'm a big, fan of data, obviously, and I think it's how we think about the world now. Things are changing. The value of an MBA, I think, is becoming increasingly dependent on understanding data and how to use it. And we're really trying to stay ahead of the curve on this at Anderson by keeping our students kind of prepared. So hopefully, at some point, for those of you, I know we have some of these. I know Jill's involved in some of these lifelong learning programs, but we've talked about making material like this or content like this potentially available for alums who want to kind of stay up to speed on kind of what's happening. So just wanted to mention that. So I think I'm out of time or close to the end of time, but I will.
You have 15 minutes.
Oh, well, we have Q&A now, right?
Q&A time, yeah.
Okay, so that's the end of my formal presentation, but I'm happy to take any additional questions, comments. I'd love your feedback on things. Jill, yes.
I have a question on the sniff. So my mom sadly ended up in a sniff because she fell and broke her hip during the height of COVID. And I'm wondering, how was this information shared with them, and if they took any kind of measures to try and mitigate the spread of the disease?
Yeah, so it's a great question about what they can do. In general, I think, they're a little nervous of us like showing how severe this is. I will say there's a couple resources. So first, CMS makes COVID data publicly available. So if you're thinking about putting a loved one in a nursing home and you want to know how many cases have they had, that sort of thing, what their vaccination levels are, you can go to CMS's website and get that data for a specific home, like as of last week. So that's, I think, one resource. They don't, of course, tell you, how many workers are working in other facilities, which we think is the thing that really matters. What we found is that, in a nutshell, like this isn't enough to do a really sophisticated pandemic alert. Where we had hoped to go was to have like a real-time monitoring thing. We get smartphone data yesterday, and then we know tomorrow you're here, and then we can issue an alert. The problem is it takes more than a day to process a day's worth of data, because these are such huge data bases. So that's not a realistic thing. One thing we've suggested to some of the nursing home consortiums we've talked with in Massachusetts and Connecticut, they had kind of the bad outbreaks early on, and so a lot of them were thinking about this earlier than other places. What we've tried to suggest is they need an administrative solution. So what would really solve this is if every nursing home worker, anybody who sets foot in a nursing home, has to have an ID badge. And you got to swipe in and swipe out. And so then we could track, okay, this person is working here and working there and working there. Even if you did that at the state level or something, that would help. We estimate our smartphone sample is about 10% of the population. Maybe a little bit more than that. I said 50 million phones, so it's 15% or so. But but it certainly will undercount people if you don't have a smartphone or you don't turn it on, if it's not generating a ping, or you've disabled all of that sharing. So those are all limitations in the data. But yeah, it's something that I'll say, as a follow-up, what we're working on now related to this is, this vaccine mandate went into effect. And there's a big question that, you see kind of as Democrats and Republicans fight over this about, are these mandates good, right? So some people against the mandates argue, well, that's going to create an employment vacuum. Like if you impose this mandate, everybody's going to quit en masse, and then we're already short-staffed, we're not going to have enough healthcare workers. So what we're looking at is using the same data. Several nursing home chains, one of the largest is called Genesis. They have like 500 homes nationwide. They issued a mandate back in August. So we can look at and see, okay, do workers at Genesis systematically leave Genesis and go to some other place, right? Like what is kind of the cost or the spillover effects of these vaccine mandates, and is it bad for employment? That sort of thing. So it's a long answer to a short
No, but it was totally fascinating. My mind's
Yeah.
yeah.
Any other questions? Yes.
You described earlier that what's predictive is the interconnectivity, essentially, of the facilities.
Yep.
So that's predictive, and okay, that's going to create a problem. And you discover that sometime, somewhere during the course of an outbreak. Now, what can be done to then change the next step would be, what can be done at that stage to change what would otherwise be a bad outcome?
Yeah, so it's a great question about what do we do with it, what could be done. I mean, I think the short answer, it's what some facilities did is, you require that they only work in one facility. So that either means you pay a living wage and you pay them more money, or you mandate it, right, from the state or from so on and so forth. What happened anecdotally, what I'd heard early on, like in Connecticut, several of the wealthier nursing homes basically built trailers for their staff to sleep in. And they said, we don't want you going anywhere else. And, you're going to stay here 24 hours a day and sleep here. And that's it. But I mean, that's probably not sustainable on a nationwide level. So what's the answer? I mean, when, you have these nursing, so let me actually also preface this by saying, we have these laws that mandate contact hours. And actually in California, this was spearheaded by Kamala Harris when she was our AG in 2017, 2018. So she increased the number of contact hours from 3.2 to 3.5 in California. So every resident is supposed to have 3.5 contact hours with a staff member. And so, in a non-pandemic, that's probably a good thing, right? Like contact is good for the resident, it improves their health and so forth. But during a pandemic, you should relax that. You should lift that requirement, because as awful as it would be for somebody to be alone, it's even worse if they're around an infected staff member, right? So that's the kind of policy interventions that I think, the CMS knew this was an issue back in March of 2020. Like they had that report I mentioned, in bullet number 4 says, we think shared staff are contributing to this, but they did nothing about it. And so, yeah, it was a big problem. And I think if, again, hindsight is 2020, but they had some indication with that genetic analysis that people are moving from staff or patients are moving from facility to facility, which is causing these outbreaks to spread. Because again, this was during lockdowns, right? There are no visitors. So if a resident is stuck inside, which most of them were, who's bringing it in? It's got to be the staff, right? Yeah, good question. Any other questions?
Yeah, so I appreciate that comment about being hindsight's 2020, right? So how long did it take for you guys to collect all the data, glean all the data, and then synthesize and come to the conclusion? And for the next whatever pandemic, that might happen, how do we replicate that process so that the data will be delivered to market a lot quicker with better coordination, so people can respond to the analysis quicker?
Yeah, it's a really great question about sort of, how we can generalize this and kind of learn from this. For the nursing homes project, I would say this was, 3, tenured faculty, Keith and a colleague of ours at Yale, working on this full time for probably 4 months. And I mean, part of that is like getting the data, cleaning it, and then writing a paper and submitting it to a journal and, doing all of that. But the meat of the analysis was probably 3 or 4 months. Now that we've done it once, it's probably easier to do it again. But again, the real issue is that smartphone, this gravy train is going to dry up. So, we have access to this data now, but because, for instance, this is not at all available in Europe because of their privacy regulations. Like, you cannot get this data. Companies like VeraSet or others, there's Cubic, places like Q, a few of these, they've seen a huge drop in data because of Apple's change in their OS, where you have to opt in to share your data. So we've just seen kind of the pipeline shrink. And truthfully, I think I would predict in the next 5 years that Congress is going to regulate this. So, I mean, I just think that's where it's going because, we're trying to use the data for good and to say, okay, like, look what we can learn that we could not otherwise infer. But you could imagine if somebody gets a hold of this data, so for instance, I'll tell you the project we did on hurricanes, we were really interested in kind of partisanship because it turns out hurricanes, like everything else, have become partisan. And so we look at, in 2017, if you guys recall, Hurricane Irma really devastated Florida. And just before that hurricane made landfall, a conservative commentator, Rush Limbaugh, went on his talk show and said, "I'm not evacuating. This is a big hoax. It's blah blah blah." And so we wanted to see, like, did that affect evacuations? And what we find is, before those comments, there was no difference between likely Republicans and Democrats evacuating, and afterwards we saw this huge wedge emerge where Democrats were like 10 percentage points more likely to evacuate a storm, even if they live right next to a Republican district. And so, that's an example of, like, we're using this data to look back at some phenomena, and we kind of can see it. But, the short answer is I don't think this is going to continue, sadly, for our research agenda. But we'll see. Yeah, question?
Kind of like a next best good source of data to use for studies like this?
I don't know. I mean, that's like large scale. I mean, this kind of study, any of these types of studies would previously have had to rely on like survey data. So there's like employment data that's like, I'm going to sample 200 people and ask them, did you work in another facility? That has its own kind of limitations. I mean, your smartphone knows a lot about you, like where it goes. You can, if you're interested in this, like the New York Times had a bunch of really cool graphics on this using the same kind of data where they showed places that people, so one of the big topics that people have looked at are compliance with stay-at-home orders. So, if your smartphone, I mean, you could, of course, leave it at home and go out, but most people take their phone with them. So you could see, in your community, what fraction of people were complying with stay-at-home orders when they were being issued, or that sort of thing. So there's been a lot of interest in this in the last 2 years.
Do low-income people have smartphones? Like, what's the percentage of people having smartphones?
So over 80% of them, I think it's about 85% now of Americans have a smartphone.
And seniors?
Yeah, so seniors I think are the underrepresented group. Fortunately for us, the seniors in nursing homes, most of them are not going to other nursing homes, so that wasn't an issue. But I would say is the one segment. But yeah, I think smartphone penetration is pretty high at all income levels. Yeah, question?
So how did Dr. John Snow know who got cholera?
So from what I read, according to Wikipedia and other sources, he went like door to door. And determined who had died of cholera and so forth. And so he had proposed this radical idea at the time that it was in the water, that it was coming from. It's funny. I went down this rabbit hole. If you're interested, there's actually a person. There's this whole cool website by a professor here at Public Health that it's like dedicated to Jon Snow, the doctor, not the character on Game of Thrones.
One of those things.
And they said they pinpointed patient 0. So patient 0 was a baby who sadly died of cholera, and they said they think the baby's parents put like a soiled diaper the water, effectively like the drainage, and then it just propagates, right? I mean, sadly, cholera is still around a lot, right? There was a huge cholera outbreak in Haiti a few years ago. That's one of these diseases that is here. Yeah. Any other questions? Well, thank you guys all. You've been a great audience.